different jurisdiction than most of Houston, and they have different rules as far as the capacity and stuff. Because I believe the governor said we're like at 75% capacity now or something, but Harris County itself is not really doing that. They're still doing the 25% capacity. From what I understand, Bel Air is allowing the 75% capacity, so we'd be able to, if that's still going on, we'd be able to accommodate you guys as close to normal as possible. But we'll see. We'll see what happens. Maybe there'll be a vaccine soon, and we can forget about this COVID. I swear, when COVID's over, I don't want to hear that word for the rest of my life. Like, if anyone says COVID, it's going to be like my trigger word. I'm going to get really angry, turn red in the face. I'm like, nope, don't say it. That's banned. We don't say that term anymore. We don't say 2020 anymore. We don't think about 2020. It's gone. It's gone. So let's see what happens. I'm trying to stay positive, guys. I don't know what's going to happen. I mean, I'm just telling you what I've heard, but let's see how it goes. I'm staying hopeful, staying optimistic, and I know I am dying to get back in the classroom. It's driving me crazy. I'm living in my cave here at my house, and I swear I'm feeling like one of those crazy hobo hermits that live in caves. They come out years later like, oh, look at the light. What year is it? What year is it? That's how I'm feeling right now. So we're going to get through it, though, guys. One of my sayings is we get through all this together, and indeed we will. We will get through this all together no matter what obstacles we face. Push forward and get through it all together. So let's see what happens. All right, guys. So we are going to wrap up with our chapter on medical emergencies today. We don't have much further to go, so this won't take the whole class period. So let me pull it up here. And then we'll have our exam on Friday for this medical emergencies lecture.
When did the exam on?
Right?
On Friday, yes.
Oh, okay. The schedule said on Monday.
Does it say on Monday?
Yeah, it says November 2nd.
In that case, it'll be on Monday then.
I'm trying to get it out of the way.
Well, we can take a vote.
Oh.
If you guys would rather have it on Friday, or if you'd rather have it on Monday, I can do it either way. And let's go ahead and do a vote right now. If you would like to have the test on this class on Friday, raise your hand. Hang on, keep your hand up. 1, 2, 3. 3. Okay, if you'd like the test on Monday, raise your hand. Okay, I think majority rules there, Jonathan. Majority rules.
You're going to be wishing come Monday that we had done it on Friday.
So we'll stick with Monday. Yeah, I'm a little thrown off. I apologize because, as you guys see on the syllabus, normally in this class we have a lot of practicums going on. And because we're not having those right now, everything's a little bit topsy-turvy. On that subject, by the way, I talked to Miss Laura on Monday, and she has been working with me to formulate the schedule to where we can do those practicums. So stay tuned. We're going to be doing those very soon. We'll probably be shifting some classes around a little bit and have you guys coming in small groups to knock those out. But I'll let you know as soon as I know more on that. Okay, so
I'm sorry.
yes, go ahead.
If we're already using if we're gonna finish this subject, do you think we can use this class period to get ahead on the road? Just because I find that class more information and the more you go over it, the better.
You mean like review for Rad Pro?
Yeah.
We can do that if you'd like to. We can even review for this class. We can do both. Absolutely. We can do an anatomy review, something. Yeah. Would you guys like something like that for Friday? I'm not seeing very many enthusiastic yeses on that, but well, let me think about that. Okay, I'll think of something on that. All right. Okay. let's start right here, guys, because if you do remember when I was talking about the cardiopulmonary resuscitation section, we talked a little bit about the ABCs. I told you guys I was going to get back to you on that because they're constantly updating the wording of this. And from what I researched, the current wording, and I don't want this to confuse you, so I'm going to accept both of these, by the way, but the current wording as far as the ABCs is it's actually CAB now. When it comes to CPR, they're talking about what you should do in order, like first to last. You should start with compressions, check airway, then check breathing. That's what the current American Heart Association is requiring. It used to, I guess it's very old school, I guess, that it was ABC, airway, breathing, circulation. But from what the current standards are saying, they're sticking with the CAB. So do know that that would be the order as far as CPR is concerned. You're going to start compressions, check airway, then do rescue breaths or breathing, as opposed to the old way, which you see on the right there, which would be check airway first, do breathing, and then cardio compressions for circulation. So if you use either of those, I'm not gonna penalize you because that picture on the right there, I believe, is straight from your book. I don't want to confuse anybody, but do make note that the current regulations by the American Heart Association is saying CAB, which stands for compressions, airway, and breathing. So put a big star on that first picture right there. I'll send that over to you as well. I swear, like I said last time, they change this stuff every stinking year. It gets so confusing. It's like in the history of me being in healthcare, which is going on 12 years now, I swear every time I go to renew the CPR stuff, something has changed as far as how many rescue breaths, how many compressions, what's the rate, 2 to 1, blah, blah, blah. It's like, guys, please, for the sake of humanity, make up your mind, stick with something. Please, please. You're not helping people out by changing this every year. Come on. Jeez Louise. And this is where we had left off last time. I was just telling you guys once again, make sure you remember there are two types of AEDs. You got the automatic extended defibrillators, and you have the semi-automatic. Of course, automatic is going to be that most common. They're going to prompt you. They're going to go through the steps for you, tell you exactly what to do once you put those pads on the patient's chest and direct you through the process. Versus the semi-automatic, it's going to be a little more where you're involved actually pushing those buttons and doing a little bit different process. Not as automatic, of course. It's called semi-automatic. So even though it's going to direct you through steps, it'll say, go ahead and push the button to shock the patient, take your hands away, shocking occurring, blah, blah, blah. Speaking of which, I think I told you guys some homework on last Monday. I said, when you guys go to clinic, can you locate your crash carts? Did anybody locate their crash carts in clinic? Did anybody remember to do that? See a couple of you raising your hands. Did anybody ask where the crash cart might be? Because remember, that's something that you need to know should something ever occur while you're in a room. Same with those AEDs, you need to know where those are at. And those crash carts should have those AED devices on top of them. And how many guys noticed that not all the crash carts in Harris Health have AEDs? Like a lot of them do not. Anyone ever asked? Did anyone ask? I think I told you guys to ask why it doesn't have an AED. Get brave enough to ask. I really would like to know that answer to that question, since I haven't been able to go out to clinic lately. Please ask that question. I'm very curious why the Harris Health crash carts do not have AEDs. Some of them do, but a lot of them do not. Okay, so as far as cerebrovascular accidents, the one we're going to focus on, the most common type of cerebrovascular accident that we will see in the trauma world, in the medical world, in the medical emergency realm is, of course, going to be strokes. And we have a little whatchamacallit, good grief, can't think of my words today. We have what's called FAST, which are the signs that we look for when evaluating a stroke victim. This is still used today. This is the most common thing used to evaluate for stroke. And that's where you're going to first off look at the face. If you have signs of stroke, a person who's having a stroke, often their face will droop on one side. So you're going to ask that patient to smile. If they smile and one side of the face is drooping severely, that's a sure sign the patient's having a stroke. You're also going to check the arm. Does one of their arms actually drift down? So what would you do? You would ask them to lift both their arms. If one's drooping down, That'll be another sign of stroke. Speech is a big one. As you're asking these questions, are they slurring their speech? Are they slurring their words together? Ask them to repeat a phrase several times. Ask them to say their birthday, date of birth, their procedure. And if they're slurring those words a lot, that would be another sign of stroke. And then the main one, the main of all those four letters, face, arm, speech, time, of course, is going to be very vital. We've got to evaluate and get these people to the emergency room as soon as possible because permanent damage can occur from stroke. Severe damage can occur from stroke. And there's all kinds of different strokes. We're not going to go through very many of them, but do know that anagram right there of FAST, fast, face, arm, speech, and time being the most important because we have to react very quickly, very efficiently on our stroke victims. Call 911. Of course, if they're in the hospital, call a code, get them to that emergency room as fast as possible. Very serious condition related to cerebrovascular accidents. Now we're going to go through a few of what we call minor medical emergencies. Still medical emergencies, don't confuse that, but these are more along the minor realm. They're not going to be major or life-threatening as the major medical emergencies we've already went over. Those are going to include nausea and vomiting, which I'm sure some of you have already experienced that wonderful, wonderful minor medical emergency so far. I think I already told you guys, my biggest weakness in the hospital world is vomit. I can look at blood and guts all day. I can look at fluids. I can look at urine. I can look at feces, whatever. But nausea and vomiting, I don't know if it's the sound, the smell, or just the visual, or all three of those combined. It just gets me. It makes me really sick. If I ever see someone vomiting or like gagging, it really messes me up. Epistaxis. Epistaxis is going to be what we call a typical nosebleed or a hemorrhage from the nostril. That would be considered a minor medical emergency. Vertigo and syncope. Vertigo refers to dizziness. That's something I actually have. I have vertigo really bad. I have a lot of inner ear trouble, so I'm often feeling dizzy. Also, why I always drive the family vehicle because if I'm sitting in the passenger seats, my vertigo acts up and I get really sick. I get really dizzy. Syncope would be referring to a loss of consciousness. Seizures, falls, and of course, minor wounds. Minor wounds. Okay, so for seizures, we're going to focus on these a little bit. Seizures can be quite scary if you've never seen one before. I remember the first time I saw a seizure, I was actually in high school, and one of my classmates it was ninth grade, began to seize and like convulsing all over the floor, foaming at the mouth. It like freaked all of us out. It can be a very, very freaky thing that does happen with a lot of people. So what is a seizure specifically? The definition is right there on that first bullet point. That's going to be an unsystemic, keyword, unsystemic discharge of neurons of the cerebrum. That's going to result in abrupt alteration in brain function. The patient's going to seize up, lock up, they'll begin to shake on the floor. Sometimes people say swallow their tongue. They don't actually swallow their tongue, but the tongue can actually block the airway, which is why we want to check that airway very fast. And it's going to be accompanied by a change in level of consciousness. So even though this starts off as a minor medical emergency, if we don't react accordingly and check our patient and check that airway and help them, that can go from mild to severe very quick as far as that level of consciousness is concerned. A lot of these patients will lose their consciousness very quickly. That can either be mild or severe depending on how we're reacting accordingly, getting that airway open, and of course getting them the help as soon as possible to relieve them of that seizing activity that's going on. Has anyone ever seen a seizure before? Anyone ever witnessed a seizure? It can be very, very scary. Yes, very scary. And that's something also, used to, like when we were talking about CPR before and choking, used to do those finger sweeps, check the mouth on patients. They used to do it on seizure victims too as well. And because they're having those involuntary reactions, fill in the blanks there. The last thing you would ever want to do is stick your fingers in a seizing patient's mouth because they have that involuntary control of their muscles. They can clamp down your hand and sever your fingers, literally. Adrenaline's flowing, and what adrenaline does gives you that superhuman strength. They'll bite your fingers right off. That can happen. So never stick your fingers in a seizing patient's mouth. Never stick your fingers in a patient's mouth, period. That's recommended to not do that anymore for anything, because people have lost fingers. It's been revised in the last few years. So, of course, you have your mild seizures. This is a guy having a seizure right here. Oftentimes, their arms will lock up in a very weird position. They'll be shaking. You always want to put their head to the side. Sometimes these seizure victims will vomit, and you don't want them to aspirate the vomit, so you always want to put their head to the side, let that seizure pass while they're getting the medical attention they need, and make sure that airway is being maintained and open. Always be checking them, making sure they're actually breathing. If they're not breathing, of course, we would immediately go into CPR, help save that patient from losing too much oxygen. Then, of course, a severe seizure is going to lose violent convulsions. It's just going to be foaming at the mouth. They'll oftentimes be drooling. Their eyes may roll back in the back of their head. And this is the ones that we would need to get that medical attention extraordinarily fast. Make sure that airway is being maintained and opened as best we can until the proper medical care arrives to help them. These are the ones where we would most likely have to go into CPR because their airway would probably end up blocked if they're going to that severe seizure state. Here are a few guidelines here for the care of seizure patient. That's a lot. I have highlighted the major points, but you do need to know all of these points as far as the care of seizure patients. Of course, gently secure them to prevent injury. A lot of seizure victims can be a danger to themselves. If they're violently shaking, they can be an injury to themselves and the people around them. Because, like I said before, when we're having involuntary charges of neurons, it's going to cause the body to have extreme adrenaline flowing through it, and these people can get superhuman strength. I mean, I've seen people that are seizing where they'll be lifting people off the table. This where I used to work with, it was kids, pediatrics. Kids would be lifting people off of the table with the power of those seizures going on because that adrenaline's flowing and it's superhuman strength can occur. Call for assistance, of course, no matter what kind of medical emergency we're dealing with. Don't be Superman and do it yourself. Always call for assistance. Protect the patient's privacy. Do not insert hard objects into the mouth or put your fingers in the mouth. I already talked about that, why that is dangerous. As safe as possible, if you do have an elderly victim, you do want to go ahead and remove the dentures as safely as possible. If you can't get your fingers in there, don't do it. You don't want to lose a limb, don't want to lose a finger. If you're able to get those dentures out, you want to remove those because they can swallow them and choke to death on the dentures. Or foreign objects, that's a little bit sketchy because we do tell you to not put your fingers in there. If it was hanging out of their mouth, for example, you go ahead and remove that from the mouth to keep them from actually choking on whatever that foreign object may be. Do not finger sweep with the finger. Go ahead and place a blanket or pillow under the patient's head. If they're violently shaking their head, it's on the hard floor. They can actually cause themselves to have a hemorrhage in the head. They can fracture their skull. Once again, that adrenaline's pumping. They have that superhuman strength flowing through their body. They can really injure themselves, injure their heads, injure their skulls, and injure their brains. Observe them and record what's going on. As we've talked about with everything in this chapter, you want to record and document everything very specifically to cover your bases and to help get that patient the proper care they need. After their seizure has subsided, it's very important to go ahead and put that patient in Sims position, place their face downward, and this is to help because, like I said, a lot of our seizure victims vomit, a lot of secretions come out of their mouth, a lot of drool. It's going to keep them from aspirating and choking. So as that seizure begins to subside, put them in that Sims position. That is the number one position for seizure victims to help any of those fluids go ahead and flow out naturally, keep them from choking or aspirating. And of course, we've said this a lot this chapter, maintain that open airway as best as possible to your ability. Usually by this point, after you've done all this, the proper medical staff will be there to assist that patient, get them the oxygen they need, and making sure that airway is open, or doing a tracheotomy if they have to open up that airway, if they've completely seized and closed off that airway. But best you can, keep that airway open, keep that chin elevated, make sure you're watching them closely, make sure they're not aspirating, make sure they're not choking on their own vomit or drool or any kind of foreign object that may be in their mouth. always be prepared to go into CPR if you have to. A lot of these people lose consciousness, and you have to do CPR very quickly, especially if it's a severe seizure. That's going to be our main steps as far as care for seizure patients. I have highlighted the major points. Do make sure you know all of these bullet points. Very important to know these for seizure patients. So as far as our wounds are concerned, when we're talking about minor wounds, we have what's called hemorrhages. Hemorrhaging is bleeding outside of a wound. We have burns, and we have wound dehiscence. These are the three major types of wounds that we're going to face in the hospital environment. And these are the ones that are going to fall into the more minor category, but as with everything else, if these aren't treated properly, if infection sets in, if we don't properly cover these wounds, we don't clean them, they can evolve very quickly into the severe realm, especially if infection sets in. But wounds in general are going to fall under what we call the minor medical emergency category, but they can evolve to a major medical emergency if they aren't properly cared for or treated. A lot of the burn ones especially, burn victims, they have to be treated very, very closely, depending on the severity of the burn. Infections on burn victims can occur very quickly because they're burned off so many layers of that skin. Infection will sit in very quickly, and these patients, very special care. Burn victims can be quite scary. I've seen quite a few burn victims coming on children that were caught in burning houses, burning cars, and they have severe burns. Pack them down. They have to treat that very quickly because that infection does set in. But I keep saying infection because that's going to be the main thing we're fighting for as far as wounds. We want to treat them properly to keep infection from sitting in. We got to prevent that infection. But wounds are considered minor, but can evolve to major. Always know where your dressings are. Now, you as a tech are not, you're not in charge of really dressing these wounds. It's going to be more so for the nurses. One thing to keep an eye on, if a patient's in your room with any kind of wound and that sterile dressing falls off, that gauze falls off, the Band-Aid falls off, you should not attempt to put that back. That is a general rule. That's to protect you. If you were to do it incorrectly, something were to occur, you would get in trouble. Now, you'll see a lot of techs do it. They'll put those gauze sheets back. They'll put those Band-Aids back. But as far as sterile dressings are concerned, you as a tech should not ever put that tissue back. You need to call a nurse, have them actually do that. That's a more recent change. It used to not be that way. It's a liability issue. It's a major liability issue. So make sure that you do not attempt to put those back. You need to call the proper staff to assist you to do that. And of course, document what's going on.
Will we be allowed to put like a new wrapping on, or we can't do it at all?
No, according to the current regulations, we're not allowed to do that. No, you need to call nursing staff to assist you on that. That's for sterile dressings, by the way, guys. I don't know if I misspoke on that. It's for sterile dressings. Sterile dressings only. I may have said Band-Aid. Yeah, if their Band-Aid falls off, you can put their Band-Aid back on. You can tape that back on. That's fine. But sterile dressing specifically, that needs to have a nurse come and do that. Tracy, what are you talking about? Can you elaborate on that?
Like when I was in the hospital, they had to have a wound nurse come in and put on the dressing for me. Not the nurse was taking care of me, basically.
So they had a specialized nurse that specialized in wound care that would actually come and do that. And it's a big deal because infections happen very easily. And what Tracy was saying, they actually have specialized nursing staff that specializes in that wound care. They'll come deal with that actual sterile dressing to make sure it's properly adhered to the skin, protecting that wound so it doesn't develop that infection. And that's the end, guys. That's the end of medical emergencies. I told you we didn't have much more to go there.